Welcome everyone to the November 19th Nephrology Grand Rounds at University of Washington. We have three UW nephrology speakers today, which is a wonderful event. And this is just as a reminder, the last Nephrology Grand Rounds before we break for the Thanksgiving holiday next week. Where we will not have grand rounds, obviously, and will return the following week on December 3rd. So our first speaker today is Dr. Daniel Lamb. So Dr. Lamb, take it away.
Just about to share my screen here. Can you guys see that?
Yes, looks good.
All right, looks like it's in presenter view.
Yep, we're seeing the full screen.
All right, wonderful. Well, morning, everyone. For those of you who don't know me, I'm Daniel Lamb. I'm a nephrologist and palliative care doc at Harborview. And during this pandemic, there's been an increased awareness regarding those who are invisible in our society. And when I last gave grand rounds, I spoke on concurrent care, that is dialysis and hospice provided side by side to support our most vulnerable patients. So for patients and families considering this option, I breathe a sigh of relief when I find out that the patient has 24/7 caregiving. Yet I know I'm asking a lot of them, and it's led me to my talk today about the impact of caring for a loved one on dialysis. Caregiving has been in the news a lot lately, and as many of you probably know, there's a push to include federal funding for caregivers, not only for children, but also for elders. In healthcare, we talk so much about patient-centered care, person-centered care, but what about the person who's right next to our patient in clinic or in the dialysis unit? What about the person you only hear about because they hold two jobs and make everything go at home? So anyone who cares for people with serious chronic illness recognizes the burden of caregiving on some level, and I think that includes our nephrology community. And so it's these stories of my patients and your patients and their loved ones that have helped widen my perspective on what and who person-centered care is referring to. So I have no disclosures. I thought I would start off with a few case vignettes to illustrate the complexity of our caregivers and to situate ourselves not in the patient seat, but rather from their loved one's perspective. So this is the first caregiver is a caregiver of one of my patients. She's an adult daughter of a 74-year-old widow and survivor of the Khmer Rouge, who's been on dialysis for a number of years now. She dutifully comes to dialysis with her mom every single session unless she's sick. And she also cares for her brother with schizophrenia. There's the wife of the 76-year-old former competitive rower. They don't have a lot of support. Their daughter's back in China and was really their only social support. And so during the pandemic, when I initiated him on peritoneal dialysis, she's been doing everything for him. She's essentially doing assisted PD for him. There's a granddaughter of a 92-year-old man who has CKD stage 5 on an active medical management without dialysis pathway. And she took over primary caregiving duties along with her mom for both not only him, but also her grandmother as well after her uncle unexpectedly drowned. And then there's a son of the 76-year-old man who has a multimorbidity, has been on dialysis for about a couple of years. He lives with his dad and is married with an 11-month-old and performs all the instrumental activities of daily living, cooks for him, grocery shops, takes him to appointments. And I was on the phone with him the other day and he said, I can't take this anymore. It feels like I'm in jail. It feels like I'm catering to him all the time. And I found out while I was on the phone with him that he was in Florida. It was so bad, he had to take his family with him to get away from his dad. All right, so the outline for today is to talk about the definition of caregiver burden. I'll give some background on paid and unpaid caregiving in America, and then discuss caregiving burden in end-stage kidney disease. So caregiving burden, how do we define it? It's a multidimensional concept of the harms that caregivers face in their role. And in 1986, Zare defined it as the extent to which caregivers perceive that caregiving has had an adverse effect on their emotional, social, financial, physical, and spiritual functioning. All right, so I'll talk first about unpaid caregiving in the US and then about paid caregiving. The AARP commissioned a report in 2020 looking at unpaid caregiving in the United States and estimated that about 53 million Americans provide unpaid caregiving in 2020, up from 43.5 million in 2015. So that means about 1 in 5 Americans provide unpaid caregiving. So 1 in 5 of us on this call provide unpaid caregiving for an adult in our life. It's predominantly provided by women, 61%. Most people are working, and almost half had some kind of financial impact on their life. And when you drill down on the number of hours that are spent per week, the average is almost 24 hours per week. And a third of people are spending 21 or more hours, and 1 in 5 are spending more than 40 hours per week on caregiving. 21% of people say their own health is not good, and 23% of Americans say that caregiving has made their health worse. You can imagine the variety of different activities that caregivers are performing. It can range from help with basic activities of daily living, like dressing, showering, toileting, feeding, as well as instrumental activities of daily living. So this includes grocery shopping and cleaning the house, managing finances, to medical support such as medication management, waiting through phone trees to schedule appointments, as well as emotional support. And so we've taken a bit of a high-level look at the prevalence and impact of caregiving in America. And given how common people are acting as caregivers, where does the US compare with other high-income countries in supporting its citizens who provide caregiving for an adult in their life? This is taken from the UCLA School of Public Health, where they ask a variety of different questions. And the question here is, are working women and men guaranteed any leave for their adult family members' health needs? In orange, you can see all of the countries that provide or that do not provide any leave. In yellow, unpaid leave, and green, paid leave. So in the US, we do not provide paid leave, but we do provide unpaid leave, unlike our neighbors to the north. So when you look at high-income countries, 50% of high-income countries provide paid leave, while the US does not. FMLA, or the Family and Medical Leave Act, does provide up to 12 weeks per year for qualified medical and family reasons. Notably, Washington State implemented a paid leave policy January 2020 called the Paid Family Medical Leave Program. And a federal policy is under consideration right now. So I'm going to talk a little bit about the demographics of paid caregiving, and the data that I could find was on home health aides. There are about 3.2 million home health aides in America, and their mean hourly wage is $13.50 an hour. The 90th percentile makes $17.80, and a whopping 90% of home health aides are female. Washington State pays 5th in the nation, and the pay comes in at $15.80 per hour. And when you look at the racial and ethnic makeup of home health aides, we see that 36.4% of home health aides are Hispanic, 32.5% Black, 29.3% non-Hispanic white, and 8.1% Asian. The orange bars here denote the share of home health aides, and gray, the share of the general population. And so it's striking that 90% of home health aides are women, 70% are people of color, and are overrepresented when compared to their share of the population. So it's worth touching upon the history of paid caregiving in America. Caregiving has been seen as women's work in the US and in many other countries. And this has been illustrated during the pandemic as well, with about 3 million women leaving the workforce during this time. A high proportion of Black women are working as paid caregivers, and This also has its roots in slavery. During this time, domestic work was performed by Black women and children. After the Civil War, Black women found work as domestic workers and as farm laborers, split about 50-50. And as families migrated away from rural areas to cities in the South or relocated north, Black women often found work in the home. So by 1940, 70% of Black women were employed as domestic workers. And notably, around this time, the Fair Labor Standards Act was passed. This created the right to a minimum wage and overtime pay, and also prohibited exploitation of workers. But this did not include domestic workers. It was not until 2013, when the home care rule was established, that these protections were then extended during the Obama administration. And so now in 2021, so-called human infrastructure remains a hotly debated topic in Congress. So yet, despite the low wages of home care workers, paid caregiving for extended periods of time is just simply unaffordable for most Americans. Median household income is $70,000. And so when you look at the average annual caregiver expenditure, that's about 10% of your gross salary, and fits the sort of objective definition of economic burden. On average, caregivers actually spend close to a quarter of their annual income on caregiver expenses. So the economics of caregiving for adults is akin to the childcare economy. Caregiving itself doesn't really pay a living wage, and yet caregiving is simply unaffordable for most Americans. Okay, so let's pivot to caregiver burden in end-stage kidney disease. And first, we'll talk about why it matters. Caregiver burden is associated with depression. It's been shown in geriatric populations, dementia, cancer, heart and lung disease, that it's associated with poor mental health. And that's also true in the end-stage kidney disease population. These are small studies, so a small study from Greece, Japan, and Nepal, showing that increasing caregiving burden is associated with depression. And caregiver burden is also associated with home modality discontinuation. So this was a qualitative study of 25 patients from Laura Denber's group at Penn. They interviewed 15 current and 10 former home hemo patients, and they identified 5 different themes that may facilitate or serve as barriers for continuing home hemodialysis. One of these themes was the availability of support. So it's no surprise that if you don't have support, you're more likely to stop home hemodialysis, but also caregiver fatigue was associated with discontinuation of home hemodialysis. And with the increase in home modalities, caregiver burden is going to be an issue that will need to be even more sensitive to. So what about the degree of caregiving burden? I'll start off with the data that we have for in-center hemodialysis patients, and then move to PD and home hemodialysis. There are a couple of small studies, one looking at 246 caregivers of maintenance hemodialysis patients in Iran, and then another one from Nepal. Most of the caregivers were women, and the majority had at least a moderate level of care burden. So 80% in one study and 66% in the other. And then the Nepalese study, about a third of these caregivers had moderate to severe depression associated with increasing levels of care burden. What about in the US? The FHN Trials, which our own esteemed Dr. Hall was involved in, looked at the impact on caregivers. Notably, they assessed perceived caregiver burden through surveys of patients and not the caregivers themselves. And just as a reminder, it's essentially 2 trials, one of 6 versus 3 days of in-center hemodialysis, and then another of home nocturnal hemodialysis for 6 nights per week versus 3 days of in-center hemodialysis. These participants were younger by about a decade with better functional status. You can infer based on their objective physical functioning that they are independent of ADLs, and yet they had a mild to moderate self-perceived burden of care. And there was a trend towards an increase in perceived caregiver burden amongst the home nocturnal hemodialysis group. Initiation of dialysis is a particularly fraught transition. So a couple of years ago, a group from the Netherlands published a study looking at functional status and caregiver burden after initiation of dialysis in older adults. So most of these patients were hemodialysis patients, but about a quarter were PD patients. They just had to be over 65 years of age and starting dialysis. And they recruited about 200 patients across the Netherlands with a mean age ultimately of 75 years of age. Almost 80% of them had some kind of care dependence at baseline, and I'm just showing you this figure to show the variety of different things that people had at baseline, including impaired ADLs or IADLs. And so before I present the data on caregiver burden, I think it's just worth noting that a substantial proportion of these patients had a decline in their ADLs or IADLs, so about 41% total by the end of the 6-month period. I do want to note that about 50% of people had either improvement or remained stable in terms of their functional status. But nonetheless, there was a decline across the board for many of the participants. And they interviewed caregivers, about 92 of them, and noted that there was, the caregivers noted that the people they're caring for had a deterioration in their ability to perform some daily activities, had some neuropsychiatric symptoms. The caregivers themselves also had an increase in caregiver burden over the 6-month period from 23% to 38%. And you can see that some of the tasks here reported deterioration in IADLs and activities of daily living. So what about inperitoneal dialysis? Last year, a single center study in China was published on 170 caregivers and 170 patients. 60% of caregivers reported a mild to moderate burden and 21% with severe burden. But what I found kind of interesting was how much time people were spending doing caregiving. So 60% of people were spending more than 4 hours a day. So that's about 28 hours per week or more. And then 1 in 5 were spending more than 12 hours per day. So that's an equivalent of an 84-hour work week. And increased caregiver burden was associated with frailty, a lower income, longer hours, longer dialysis vintage, and less exercise. I surmise likely because they have less time. So I mentioned earlier that caregiver burden is associated with discontinuation of therapy, and severe caregiver burden can lead to burnout. So this was a qualitative study looking at patient and caregiver perspectives on burnout in peritoneal dialysis. It was a multinational study from these 3 countries, Australia, Hong Kong, and the US, looking at 81 patients and 45 caregivers. And this is a graphic here of 2 of the major themes that were identified. 1, suffering and unrelenting responsibility, and 2, adapting and building resilience. So it's no surprise that, you know, if you're doing PD and you're not doing it just for 1 day or 2 days or 1 week, 1 month, some of these patients and families are looking at this as essentially a destination therapy. And so they can become overwhelmed by this daily task that they need to do, and it can often feel isolating. And yet there are other ways in which they can establish a new rhythm, a new routine that can help them feel more empowered. I think it's particularly important for us to have caregivers find support away from or outside of the patient that they're caring for, and also encourage them to engage in self-care activities so that they can have a break from the caregiving. I'm going to take one quote from this particular study from a caregiver, and he said, "As being the carer, it also makes you feel burnt out as well. And then there's times she doesn't feel like doing it because I don't blame her. It's physically draining at times. I'm physically drained as well from work and doing other stuff as well. So then it does make it a bit difficult when someone has a burnout." So this is a caregiver in his 20s. Okay, so now switching to home hemodialysis. This was a systematic review of 24 qualitative studies looking at the entire sort of experience of home hemodialysis. Looking at they interviewed 220, or it was looking at 221 patients and 121 caregivers. And they identified 5 different themes. One of them was concern of family burden. So I'll take a deeper dive into this. They had 4 additional subthemes that they identified: emotional demands on caregivers, imposing a responsibility on caregivers, family involvement, primarily in decision-making, and then medicalizing the home. I think so the quotes can flesh out what these subthemes really are. And so I'll take a few selected quotes. So this is regarding the subtheme of emotional demands placed on caregivers. So this is a quote from a caregiver: "Having to watch my father every minute of every day is intolerable." And another caregiver said, "I had a meltdown. I got to the point where I didn't think I could go on." And relating to the responsibility that caregivers had, one caregiver said, "Home hemo is 100% more burdensome. I wasn't involved before. He would go away 3 hours, 3 times a week, and that was that. Now it's this obnoxious burden." Another caregiver said, "Never-ending caregiver job." And a patient said, "Nobody talks about the impact on caregivers, on family members." And finally, a caregiver essentially defined what caregiving burden is: affecting family income, recreational activities, vacations, and living arrangements. With regard to sort of the decision-making process, you can see a bit of sort of different perspectives. So there's one patient, or one patient who said he wanted to do home dialysis, but his wife had refused. While another said, well, his wife essentially didn't want the disruption of having to go somewhere else, and sort of encouraged him to do home dialysis. With regard to the subtheme of medicalizing the home, while we may not traditionally think of this as part of caregiver burden, the supplies, the machine, and the routine of performing the procedure become a permanent part of the built environment and family rhythm. And I think it's best illustrated by this quote here from a patient who said, "Look at my private hospital." And I think it's worth noting, this patient is still choosing their own private hospital as opposed to someone else's private hospital, and that's maybe preferable than going in center. Finally, there were themes around social isolation, and there are a couple of caregivers who said, "I don't get much time to myself, 10 minutes in the yard with the dog if I'm lucky." And another who said, "Only a handful of friends could handle coming in here when he is on the machine." So, we have a sense of the ways in which people experience caregiver burden, but recall that there were a number of other themes with regard to home hemodialysis, and that this was also seen as an opportunity to thrive. And patients and caregivers really emphasized the autonomy that they had through home hemodialysis compared to other modalities. And one caregiver summarized their experience by saying this: "The way that dialysis was presented when the patient got sick was, you're going to go on dialysis, life is great. There was no understanding or reality of how tough it is, and an acceptance that it's tough, but you can do it and that you will cope." It was like it took us years to figure out that it was okay not to cope and that we've learned. And my hope is that we can cut down on this, that it takes years for people to cope with the transition to dialysis. And to have people say something more like this: "In the beginning, I didn't believe I could do it, but I don't think it's particularly difficult now." So for our patients and families to thrive, caregiver burden is an issue we will need to address in our practice as individual clinicians and on a health system level, as well as on a policy level. I know we expect that our home programs will continue to grow, and we'll need to find ways to mitigate caregiver burden for our patients to succeed on their preferred modality. And so I'll leave you with a few potential strategies to address caregiver burden. This was taken from a couple of studies looking at the PD population, so encouraging and offering counseling and peer support for our caregivers for psychological and emotional support, being flexible in prescriptions to reduce caregiver burden as appropriate, and offering assisted in-home peritoneal dialysis if available, or certainly advocating for that on a policy level, and offering a period of in-center PD as respite care also if it's available. My understanding is that NKC currently does not have an in-center peritoneal dialysis respite program, but you can use IPD potentially for a few days to give a caregiver a couple days of relief. One simple thing that we can do in our clinic is empathic listening. And so in a terminally ill population, empathic listening by physicians has been associated with a decrease in depressive symptoms amongst caregivers, as well as a decrease in perception that caregiving is interfering with their lives. And as many of you know, I have a deep interest in palliative care, so I want to leave you with a perspective on how palliative care may assist in caregiver burden. So this is a pilot RCT out of Hong Kong, where they looked at 29 pairs of caregivers and patients who are pursuing active medical management without dialysis. So all of these patients were referred to a kidney palliative care clinic and followed for 6 months. The intervention group also had enhanced psychosocial support through a palliative care nurse and social worker. And so this was associated with a decrease in caregiver burden, anxiety, and depression scores over month 1, 3, and 6. So to summarize, caregiver burden is a multidimensional concept that affects emotional, social, financial, physical, and spiritual domains. And caregiving burden is associated with depression and home modality discontinuation. Caregivers for dialysis patients experience a considerable degree of burden, and there are strategies for all of us as kidney care professionals to reduce caregiver burden, but more work is needed to be done to develop additional interventions that are effective for the end-stage kidney disease population. So with that, in this Thanksgiving season, I want to thank all of you for listening, and also want to thank all the caregivers out there.
Thank you so much, Dan. Wonderful talk. Obviously, something that many of us believe strongly in, and thanks for sharing all your research. It looks like there is a question or comment from Susan. Go ahead.
Thanks, Dan. That was such an interesting talk, and it's kind of a comment and a question that I have. I was wondering about your perspectives on the notion of relational autonomy. And so kind of more in the recent decades, feminist kind of ethics have slowly entered or infiltrated the medical ethics realm, where medical ethics has always put a lot of value on patient autonomy. And feminist ethics kind of raise this notion of relational autonomy. That is, you know, if a patient is going to succeed at manifesting their own autonomy, their own autonomous choices, it really requires complete caregiver collaboration and buy-in. And so where do we make room for the caregiver's autonomy in this? And so I was wondering about your perspectives and any tips you had in navigating that family meeting in the clinic. I definitely think empathetic listening is very helpful, but I just wonder if you had some like tips or tricks about how to kind of make a recommendation that, you know, how do you negotiate that when you've got these two different voices kind of in the room? Yeah,
over time. I mean, I think one thing to remember is that, you know, these complex family dynamics, they didn't happen overnight. And so I think we're not going to fix anything in one meeting. But what you can do is try to help people articulate their values and then see where their values are shared between caregiver and patient. And then based on that, you can help them to negotiate what the best path is moving forward. So, you know, there's probably a lot more to that, but it's worth a day-long discussion or more.
Some comments in the chat from Raymond, Amal, Chris Blosser, all seconding my comments about what a great talk.